Welcome back to the SIS case review community. I'm here today with Dr. Tina Molumphy, who's going to guide us through a case of Bertolotti syndrome. Tina will present the case, which she brought to our attention, and then I'll give you a little background on Bertolotti syndrome. I hope this will stimulate some of you to bring us interesting cases, because we're always looking for good ideas of things which you see that we can elucidate and expand upon. So Tina, I'll let you present the case.
Thank you, Tim, for allowing me to participate in this wonderful weekly stimulating conversation. I was approached by one of the surgeons in my practice with this 36-year-old male. He was involved, unfortunately, in a work-related automobile accident approximately 4 years ago. He sustained at that time significant lower back pain on the right side. Imaging was done in the ER, nothing was abnormal. Sent to physical therapy. I also must mention his BMI was 38, and his pain score when he came to see me at my practice was 6/10 in intensity. Like I said before, he had physical therapy. He's also tried some acupuncture. Not sure why in his medical chart, it said he had some radiofrequency ablation in the higher levels. Not certain why that was done, but I did talk to the interventionalist whom did bilateral L3 and L4 transforaminal epidural steroid injections, which provided significant relief for about 5 months, 75%. But then workers' comp denied further injections. The patient was then seen by a surgeon at my practice, and he was then referred to me for possible injection. On exam, he had a negative straight leg raise, slight radiation into the right buttock, but not below the knee. His deep tendon reflexes were equal and symmetric. Strength was great throughout. SI joint provocation tests were positive, at least in 3 out of the 5 maneuvers. And he had tenderness over the right upper SI joint slash L5-S1 facet region. If you can see here, he's got the enlarged transverse process over here, and this is articulating over here, I believe, with the top of the sacrum. Cannot see much on the lateral view. It was reported on his MRI that he also had a transitional segment at L5. He had L3-4 moderate central canal stenosis, which is probably why those injections with epidurals helped. He had some congenital narrowing of the central canal and mild stenosis at L4-5. On his MRI, I have here the off to the right sagittal views and axial views over here. You can see that the transverse process is extensively long on both sides. Over here on the right side, it wasn't well defined in terms of the bony articulation, and therefore a CT scan was ordered. I've just included a couple slices here, but you can see over here, especially in the axial views, that there is a articulation that looks like a false joint right here. This is his facet joint. And you can see on the far lateral, on the sagittal view, it looks like it's articulating with the top of the sacrum. Therefore, I brought him into the fluoro suite and placed him prone and did, as the surgeon requested, an injection into that false joint. Back to you, Tim.
Thanks, Tina. This is a case of Bertolotti syndrome. So let's talk a little bit more about what that is and what it means. Here's just another similar case. This was a 28-year-old female. She had right-sided axial pain at the lumbosacral junction. And here are her frontal images. And she has a pseudarticulation on the right. And notice on the lateral image, as you could see somewhat on Tina's case as well, there are parallel end plates and this very block-shaped rectangular vertebrae at the lowest lumbar level, demarcating that as a transitional segment. This patient had an MRI, and here we can see the pseudarticulation and some dark signal on the T1 weighted image, suggesting that there's some marrow edema. This is an older case, so here was an old tomographic images from a SPECT scan, and there is some increased uptake on that right side. And this patient did indeed have pain related to this pseudarticulation, very much as Tina's case showed us. So what is Bertolotti syndrome? Well, it was initially described by Bertolotti in 1917, and it simply describes the association between a transitional lumbosacral vertebrae, a TLSV, and axial pain. It doesn't really tell us where that pain is coming from. It doesn't specify a specific mechanism, and we'll talk about those mechanisms in a few minutes. Now, these transitional segments are pretty darn common. In several series, it can range from 4 to 36% of the population with a mean of around 12%. So these people are in your procedure room every day if you look for them. They're more common in males, and when they're unilateral, the malformation is more common on the left. And we use the Castelvi classification to describe them. And this classification, which goes back to about 1984, describes type 1, the most common type, and this is simply a dysplastic transverse process, and it's unilateral if it's subtype A or bilateral if it's subtype B. Type 2, there's incomplete sacralization, as in our index case, where we have a pseudarticulation with the top of the sacrum. Type 3 is where there's complete sacralization, meaning there's fusion between that enlarged transverse process and the top of the sacrum. And again, unilateral or bilateral. And then type 4 is mixed, typically a type 2 and a type 3. So a pseudarticulation on one side and fusion on the other. And this illustrative case, again, just shows that pseudarticulation here, and then simply an expanded transverse process on the opposite side in this mixed case. Now, what's the association with low back pain, particularly relevant to the Castelvi type? A large series by Nardo and colleagues looked at a population of patients, and when there was no transitional segment, 53% had back pain, so a 53% prevalence of back pain in this patient population. Where there was a type 2 transitional segment, now the prevalence of back pain was 73%, and in type 4, it was 66%. And the overall analysis showed that Castelvi 2 and 4 were associated with an increased prevalence and severity of low back pain and lower overall physical activity levels. In another population-based study by Tang and colleagues, type 2 transitional segments were associated with low back pain with an odds ratio of about 2.5. Gluteal pain brought the odds ratio up to 5.3, 5.38. In type 4 transitional segments, the low back pain odds ratio was 4.3, and gluteal pain well up to nearly 7. So certainly something to pay attention to. Now, what is the underlying structural pathology that might be underpin the pain exhibited by patients with transitional lumbosacral segments? Well, certainly disc herniations in transitional lumbosacral segments occur more commonly and at a younger age when compared with patients who don't have a transitional segment. And those disc herniations occur at a different site. In transitional lumbosacral segments, those herniations tend to occur at the supra-adjacent level, the level above the transitional segment. And this is in distinction to patients who don't have a transitional segment, where usually they're the penultimate disc, the second lowest mobile disc, usually the L4 disc, is the dominant segment which has disc herniations. So in a transitional lumbosacral segment population, we're seeing herniations at the lowest mobile segment because the transitional segment is typically non-mobile. In a non-transitional segment population, we tend to see disc degeneration and herniations at the second lowest mobile disc. So there's definitely a difference in the way axial load is transmitted and where those discs undergo degeneration. Herniations or degenerative change below the transitional segment is very rare, and that's simply because there's no motion there. So we'll typically have preserved T2 signal in that disc immediately below the transitional segment, and that disc is often kind of vestigial or partially formed in nature. We can also have radicular pain in patients with transitional segments. And here there's compromise of the nerve, usually just the ventral ramus, as it goes under that pseudarticulation, and this is called the far out syndrome. And this doesn't refer to psychedelics or other issues, but simply refers to this being a far out or a far lateral compromise of that ventral ramus. And here's some illustrations from a paper by Ichihara, and here they've done a periradicular injection. This is probably an epineural injection, actually. See that striation there? And on the axial image of CT, here we can see the ventral ramus is going to be significantly constrained here as it leaves this overgrown transitional segment or pseudarticulation here. And on this other illustration from that series, again, we're going to see constraint or compromise of the ventral ramus out here. And here's this overgrown suit articulation, quite sclerotic on the plane radiograph. And that is going to impinge on the exiting nerve at that level. So that's the far out syndrome. Other structural pathology in transitional segments, as in the index case we presented here, when we have a unilateral suit articulation, there can be asymmetric loading. And there we may see osteoarthritic change in that suit articulation, as in Tina's case. We may also have ipsilateral SI joint excess load, which may contribute to why your patient had some SI joint positive provocation features. There also may be challenges in the contralateral facet. And then we've talked about disc degeneration. There's an interesting case report from Mayo done some years ago where there was an asymmetric suit articulation. The patient had pain contralateral to that suit articulation. The facet was blocked on multiple occasions. The contralateral facet, that relieved the pain. So ultimately they resected the suit articulation and the patient's pain was relieved permanently. So that the presence of that suit articulation can result in some asymmetric load that can affect the contralateral facet. If we look at patients who have young patients with low back pain and had type 2 transitional segments who underwent SPECT scans, 80% of those had an increased uptake in that suit articulation. And in 63% of those patients, that was the only SPECT abnormality. Certainly not ultimate proof. The anesthetic injection, particularly a controlled anesthetic injection, is the ultimate proof, but it strongly suggests that there's physiologic abnormality at those suit articulations that show signs of osteoarthritic change. The other thing we always have to remember in patients with transitional segments is there's likely to be an enumeration challenge here. If you have a transitional lumbosacral segment, there's a 7-fold increased likelihood of an anomalous number of presacral vertebrae. And that can present you with challenges with associating or correlating between your MRI and your imaging in the procedure room with fluoroscopy. Note that those patients also have anomalous dermatomal innervation, so they may present with unusual radicular pain patterns. So lots of things to be careful about in patients with transitional lumbosacral segments. Here's some examples on plane radiographs of those transitional segments. Here we have suit articulations on both sides. Here we have a suit articulation and simply an enlarged transverse process. Here's simply a dysplastic transverse process. And here on the sagittal or lateral image, we have these absolutely parallel end plates. Here we can actually see some bridging bone anteriorly and posteriorly. And this emphasizes to us that there's usually no motion at that disc. And that's why that disc is going to have nice preserved T2 signal in it. Here's a suit articulation and an enlarged transverse process on another frontal image. And again, another example on the lateral view of this very squared lowest lumbar segment. And then these absolutely parallel end plates, no lumbosacral angle, indicating there's no motion here. But overall, one thing also to remember is these patients tend to have exaggerated lumbar lordosis. In terms of diagnosis and treatment of Bertolotti syndrome, beware that many of these may be asymptomatic. Probably the vast majority of them are asymptomatic. A diagnostic local anesthetic injection at those suit articulations, there's anecdotal and uncontrolled evidence that can identify a pain generator. We showed you some SPECT images. SPECT imaging is a good diagnostic complement or correlate to the structural changes of osteoarthritis, but there's been no controlled study definitely identifying that as a pain generator. In terms of therapeutic interventions, a corticosteroid injection at that site in small case series or case reports can be helpful. RF ablation certainly makes conceptual sense because that suit articulation should be innervated by the medial branch of the dorsal ramus. So that has also been reported in small series. And as I mentioned earlier, actually resecting that suit articulation. And all of these interventions don't really have any controlled evidence, just small case series and reports. There is a proposed algorithm for looking at Bertolotti syndrome where we have a transitional lumbosacral segment and low back pain. Treat them conservatively. If there's no improvement and on physical exam, there's correlation of their pain with a pseudarticulation, then it's rational to go ahead and do an anesthetic block and do a steroid injection as well would be reasonable. If you really want to make that diagnosis, a controlled block, 2 blocks would be ideal. If they get long-term improvement, fine. If they don't, then you could consider RF ablation or actual surgical resection. And if they don't respond to the anesthetic block, you've essentially ruled that out as a pain generator, and then you have to go down the list of other causes of axial pain, recognizing that in patients with transitional segments, ipsilateral sacroiliac joint pain is going to be more common. Degenerative disc disease in the segment above the transitional segment will be more common. There may be more commonly herniations at that level above the transitional segment, and there could be contralateral facet joint pain. Here, now I'm going to just show you some examples from my practice over the years of this syndrome. Here's a young female with left-sided axial pain. Here's the frontal radiograph. So there's the pseudarticulation here. And this patient had a SPECT CT and it was hot as blazes. And when we did the injection here, the pain was completely relieved. Here's another somewhat older case. Notice there is some spinal dysraphism present at that level. But here's the pseudarticulation. Again, here was a T1 weighted MRI, and notice the signal is dark, indicating marrow edema at that pseudarticulation level. And here's the CT going right through that, and we have some little bits of nitrogen gas indicating a degenerative phenomena, very much like a disc or a joint. This was injected and did indeed relieve that patient's pain. Just another example, here's a pseudarticulation, and here we can see that anterior aspect of that neural foramen. And sometimes if you look at this, you'll see that this is a really small hole, and that's going to be those patients who have that far out syndrome. If the patient has radicular pain, then you want to do a cross-sectional imaging study and see is there a constriction of that little channel quite far anteriorly where that nerve could be being constrained. This patient, however, had simply axial pain. So again, we injected the pseudarticulation. This was one where there was not a true pseudobursa, as may be the case. In contrast, simply accumulated around the pseudarticulation. Another example, a relatively young female, left-sided axial pain, pseudarticulation. And here is a CT showing this very unusual looking pseudarticulation with some osteophytic formation. You can see where this could be moving towards that far out syndrome out here. And here on a coronal CT reconstruction, there's the osteoarthritic change with some sclerosis and these osteophytes, which are going to encroach close to that exiting lowest lumbar nerve there. And this patient, we injected into that pseudarticulation because they had axial pain. And again, this was one where there was a pseudobursa and just accumulation in a constrained space here. And they did indeed have pain relief. This patient had some lateral side bending and had left-sided focal axial pain. And again, a pseudarticulation between a transverse process and the sacral ala. Lots of degenerative phenomena at that pseudarticulation. When you get them under the fluorosuite, you can often find a nice opening there, though even though it wasn't greatly evident on the plain radiograph. And this was another one where there's a nice pseudobursa, a very constrained space. Notice there's some gas in some air injected into that constrained space, as well as contrast material. Neither of those were present on the scout image. So this was a constrained space of about 1 cc in the capacity. Another example, pseudarticulation, prone patient, injection into that pseudarticulation, and pain went from 9 out of 10 to 1 out of 10. Bilateral pseudarticulations here, but pain only in one side. So we injected the symptomatic side, and again, a constrained space. Beware, sometimes these will communicate with the upper SI joint. I've seen that as well. And that's what we see in this patient, where we're injecting this side, and now there's some communication with the upper SI joint. So to sum up, Bertolotti syndrome is the association of a transitional lumbosacral vertebrae with low back pain. Transitional lumbosacral segments, remember, are very common, up to 30%, 36% of the population. Many will be asymptomatic, but they can be a cause of axial pain, and there are several possibilities for why there's that axial pain. Castelvi 2 and 4 types of transitional segments are commonly associated with low back pain. Those are those which tend to have an asymmetric SUT articulation. The axial pain generators include the SUT articulation, the contralateral facet, the ipsilateral SI joint, or the supra-adjacent disc. The diagnosis of SUT articulation pain is going to be looking at an MRI and looking for marrow edema or a positive SPECT scan at that site, and then confirmed with an anesthetic injection, preferably controlled if possible. If the patient presents with radicular pain, think about that far out syndrome, and you're really going to have to look at cross-sectional imaging, probably best with CT, to really identify that stricture or constraint of that anterior aspect of that neural foramen. And then there's been, as far as therapy, also anecdotal use of surgical resection of those SUT articulations. So I hope this has been somewhat useful in kind of expanding on Bertolotti syndrome. So I'm going to bring Tina back in here and see how her patient did.
Thanks, Tim. It turns out the patient saw the surgeon 4 weeks later after my injection, and he reported significant reduction in his pain from 7 down to 2, and the pain that radiated into his buttocks was gone.
Excellent. So let's see how this pans out. Hopefully this will be a durable pain relief. Obviously you can repeat the injection if necessary, and hold an RF ablation in your back pocket is something that you could consider as well if the local injection is not sufficiently durable.
I have another case very similar to this that I'm doing tomorrow, injecting her. She had been through several epidurals. I think she had medial branch blocks as well, lumbar spine. Came to me, she's been in bed rest since March. She's like a triathlete, really active person in her early 60s. So I saw on her x-ray she had this transitional segment, but it's on the opposite side of her pain. And you just mentioned that you look at the facets on the opposite side. I was planning on doing a diagnostic only SI joint injection because her SI joint provocation maneuvers were positive, but you're saying it's more likely her facet joints?
I don't know if I could say it's more likely. If you have positive facet SI joint provocation maneuvers on the side of pain, I think that argues pretty strongly for that. But if that doesn't provide substantial benefit, then I would keep that contralateral facet on the side of pain, but contralateral to the SUT articulation in hand as something that could be a pain generator as well. So I might have that as plan B if the SI joint doesn't get the patient where they need to be. The case from Mayo that was reported, they were interesting. They had a SPECT scan and the SUT articulation lit up, which was contralateral to the side of the pain. And right. The facet joint, which was stressed and was painful, did not light up. And there was no obvious osteoarthritic change. So it must have simply been, strain in the joint capsule from the asymmetric load bearing. So I'd keep that in mind as a possible cause of this patient's pain. But if you've got 3 positive SI joint maneuvers, then I'd probably do the SI joint first.
Okay, thank you.
That makes sense?
Yep.
Yeah, interesting stuff. So I'd like to thank you all for your attention. Thanks particularly to Tina for bringing this case to us. And I'd like to encourage you all, if you have an interesting case, an interesting contrast flow pattern or an interesting imaging case, please bring it to our attention and we'll try and build a case around it. So we look forward to hearing from you. Stay safe and stay sane. Take care.
Well, thank you for letting me participate. I greatly appreciate it. It's been super fun.
Keep track of how that patient goes and let us know how it pans out, because we could potentially do a, hey, remember that case?